All right, my name is Madison Rader, and my capstone is titled Early Mobilization Protocol Integration for an Intensive Care Unit and includes a facility analysis, implementation strategies, and multidisciplinary approaches. So the first part of my capstone was the scoping review. So as we know, just generally across the literature, we know that early mobility is safe and effective, safe primarily, and effective for meaningful for critically ill patient populations in the ICU. But protocols vary across institutions and providers. So the purpose of my scoping review was to analyze the components and themes of successful early mobility practices that include occupational therapists specifically, but also the integration of the entire care team for critically adults admitted to intensive care units. So here is my PRISMA diagram. Basically states that of 253 identified studies, 49 underwent full text review with 14 final articles selected by myself and a secondary peer reviewer. The six key themes that emerged within all 14 of these studies and that were later addressed by the protocol that was developed for this capstone project was initiation of mobility within a designated time frame, standardized approaches to patient intervention, individualized assessment of progression based on patient status, interprofessional collaboration, professional development, and utilization and creation of staff resources. So, background on the case, Mount Carmel East Hospital is a large acute care hospital in central Ohio, around 400 beds, and it is the third largest hospital for adults in the central Ohio area. It has four intensive care units. I was primarily in the trauma ICU, but there is also a med surge. There is also a neuro and a cardiac. OT and PT practitioners at this facility report a general dissatisfaction with current early mobility practices within these ICUs. Prior improvement efforts have been attempted and unsuccessful due to structural, social, and organizational factors. OT and PT practitioners, nursing staff, rehab administration, and critical care nursing clinical educators recognize both the importance and the benefits of early mobility and the need for change. The final algorithm to your right is based on both the intersection of the existing literature, what works in evidence-based practice, and what is available and accessible at Mount Carmel East Hospital. So the final algorithm includes just the medical, surgical, and the trauma ICUs. The cardiac floor has its own completely different protocol, just based on the surgeons on that floor. And these were the types of ICUs that were most frequently mentioned in the 14 studies that were included in the scoping review. Outcome measures like the CAM ICU for delirium, the AMPAC as completed in acute care hospitals, MRC score for ICU acquired weakness, activity achieved through the protocol, which I'll talk about, and qualitative data. And then intervention includes therapy eval within 24 hours, if held, reassessment in 24 hours, patient assignment to mobility level, indicating mobility with nursing and therapy teams, consistent nursing level mobility, and coordination with the medical team. Frequency and duration, as kind of identified through existing evidence, is work with OT and PT for an average of 25 minutes a day, daily, and then mobility protocol continuation by nursing and tech staff. And then the target outcome is improvements in patient and functional mobility at the time of ICU discharge. Pragmatic considerations, of course, fluctuations in medical status, family involvement, goals of care, staffing, productivity, and equipment. So through my facility analysis, I kind of got to look at the outcomes related to acceptability, adoption, and feasibility of the proposed protocol. So the outcomes for barriers to implementation were either of educational, interprofessional, or structural origin. The chart on the left kind of breaks down each type of barrier, so educational, structural, interprofessional. And then the chart on the right goes through each strategy. So nursing level education and orientation, adaptation to kind of suit the needs for nursing staff, department-wide standardized resources for therapy, mobility protocol, continued education and evaluation, and facilitation of evidence-based practice strategies. Structurally, integration and embedding of ICU-specific therapists, protocol integration, equipment, procurement and allocation, and then interprofessionally, integrated professional development opportunities between therapy and nursing, OT and pre-T presence within all ICU rounding, and then education and involvement of the family and the patient as a so the Capstone experience kind of included all of the small components and steps that I took to kind of address the barriers and the strategies that were identified by my facility analysis. And these were presented in a acute and critical care wide therapy meeting at Mount Carmel East for all of the therapists. And then some educational materials were developed. So the material on your right here is a therapy decision tree. This was developed to guide the safe initiation and progression of therapy sessions for critically ill patients. This promotes provider consistency by clearly outlining through current evidence and current Trinity Health protocols for the initiation or cessation of therapy sessions. It supports multidisciplinary communication several times throughout the decision tree, encourages daily reassessment by therapy, and guides adaptation of mobility approaches. The next was embedded into the final algorithm from earlier slides, but this is the multidisciplinary protocol to your left. This was developed in collaboration with staff therapists based on, again, evidence, the identified articles through the scoping review, and the existing materials at Mount Carmel East. So this is protocol development for the final algorithm based on existing practice patterns and identified needs. So this is for nursing staff, this is for the medical team and therapy professionals, including patient status to be assigned to guide nursing and tech intervention, as well as therapy goals and activities for each level. Another resource that was developed was the objective measure resource for OT and PT for use in specifically critically ill patients. So assessment tools that were identified through this resource were for mobility and strength. So the FSS ICU, the PERME ICU mobility score, the MRC score, and the ICU mobility scale, as well as cognition and delirium. So the CAM ICU, the MOCA, the ICDSC, the CRSR, and the ACE and mini ACE. So these objective measures, documentations for the EMR, and associated literature were included to kind of guide evidence-based therapy evaluation in ICU. Nursing and patient educational materials were also developed. So early mobility in the ICU was just one example. But I collaborated with the Patient Education Committee at Mount Carmel East to develop and publish 5 patient and caregiver educational materials on early mobility and ICU-related conditions that reciprocally impact mobility. So this includes early mobility, delirium, ICU-acquired weakness, and PICS, which is post-intensive care syndrome. This resource was developed to all Mount Carmel East health system institutions, so not just Mount Carmel East, but also all of the Mount Carmel hospitals that exist. But these resources were kind of developed to further engage patients and their families as applicable in the early mobility process. And then some nursing educational materials were also developed. This is just one example, but these included the passive and active range of motion, delirium, post-intensive care syndrome, and ICU-acquired weakness, further clarifying the roles for nursing staff in early mobility with the key takeaways that were developed into each chart at the top right for easy, accessible communication through rounding opportunities. Additionally, during this time, I got to shadow other professions involved in acute and critical care. So physical therapy, nursing staff, but also speech language pathology and respiratory therapy. I facilitated a monthly critical care interdisciplinary journal club for OT and PT staff members. I attended various CEU courses and I earned the Medline Mobility Scholar title, which centers on mobility practices to empower safe and effective early mobility. The references included to your right do by no means encompass all of the references that were utilized in my capstone project, but these 4 were most frequently utilized for the development of this particular poster. And then for acknowledgements, I would like to express my most sincere gratitude to my capstone advisor and my capstone mentor, Dr. Ann Bartman and Aaron Ball, for their guidance, mentorship, and support. Thank you so much.